So I'll say good evening, good afternoon, and I will say good morning to you, Professor and Dr. Bob Gish. How are you?
Thanks
for having me. Sir? Pleasure. Always a pleasure. So, right, we're going to start with the caveats. So, firstly, what we're looking to do today is to give you general medical information. We're certainly not here to give you individualized medical advice. What we're trying to do is to give you the information, confidence, empowerment, to have a much more informed and engaged conversation with your clinician or physician or provider, as we've got an American guest today. So we're not, again, trying to take the place of that consultation, but what we're trying to do is empower you in your conversation and make sure that you're able to ask the questions you need to get you closer to the answers you need. So that is the aim for today. We have Dr. Bob Gish with us, who is anywhere around the world on any given week. Today he is in Sacramento. It sounds lovely. Is Sacramento as nice as it sounds?
It is. It's a great city. It's flat. It's on the Sacramento River Delta that feeds the bay. Salmon run through here. The town is nice and clean. Good weather. Nice to be here.
Nice. Splendid. Okay, if you are in Facebook, welcome. Thank you very much for joining us. If you have any questions today, please type them in, and we will be delighted to do that. We have a couple of questions that have been sent in before, so we'll do that. Now, one of the questions that's been sent in is in and around fatigue. So what I thought we might do, Bob, if you're happy, is to spend a little time on fatigue, maybe talk about how we differentiate between PBC fatigue and any other fatigue. So, when you look at vitamin D or iron or vitamin B12, thyroid, rheumatoid arthritis, there are many, many conditions that can lead to fatigue. So let's start there. How do we differentiate between the fatigue that we think is caused by PBC and fatigue that's caused by anything else?
So that's a fantastic question, Robert. I've never been asked that question, and I had to think, is the fatigue of iron deficiency and anemia different than the fatigue you get from PBC or another cause, maybe B12, maybe you've got a bad arthritis? So I usually start off thinking that the PBC fatigue is central. It's in the brain, and we don't fully understand it, but it's probably part of an inflammatory condition.
Yep.
And if we can reduce inflammation, I think that fatigue would be less. That's a general theory. If you have iron deficiency, anemia, and fatigue, you might get short of breath walking upstairs or trying to exercise at any type of altitude. I don't see shortness of breath as being part of the PBC fatigue. So that's one question I would ask. So I work more on, fatigue is sort of a continuum, and I talk to the patients about the severity of that fatigue and what their quality of life is like, how much they can do, how much they can't do, and then start working on that, as well as getting to the source of the fatigue. And I can talk about that in a moment, but I'll stop for a second to give you a little time to branch out.
Okay. No, I appreciate that. And I think I love the approach of looking at it as a continuum, because, with or without PBC, everyone has good days, bad days, high energy days, low energy days. And you're absolutely right that, any patient on any given day can be anywhere on that spectrum. So we know at the moment there are no licensed therapies for fatigue. I know there are many questions in terms of kind of herbal things and those kind of things that you could use. Obviously, coming from a patient support group, I've got a view. This talk of fatigue is making Bob yawn. So where do we start? If somebody comes to you with fatigue, how do we start to address it to improve quality of life and alleviate that symptom burden?
So in the PBC world, the two biggest symptoms that I would like to focus on is number one is itching, because itching disturbs sleep. But in a bigger picture, I'm asking a lot of questions about sleep habits. So I go down that pathway. If they're not itching and they have poor sleep, that's a little bit different than if they are itching and have poor sleep. Because if they're itching with poor sleep, I go after the itching first or in combination, because we have some good anti-itch medicines that help people sleep. Doxepin is one of my favorites. There's some other antihistamines that I think work for itching for some patients and also help with sleep. Then it's sleep hygiene. Is caffeine is great for people to have energy during the day, but if they drink caffeine after noon, it can really disrupt their night cycle. So caffeine in coffee and tea is good for liver health. I think it's good for all sorts of other things. So to make it simple, sleep and itch, and then see how they're integrated.
Perfect. That's helpful. And if so, somebody doesn't have itch, but they're still coming with that centralized fatigue. Now, we've heard patients talk about walking through custard, wearing a lead blanket. Patients will often say it's as if the power is just being pulled, that somebody's pulled the plug. How do we support patients in that part of their journey? What can we do?
So we mentioned caffeine on the energy side. Of course, exercise begets better sleep and begets better energy. But if somebody's really tired, it's hard to get them to exercise significantly. So that has to be a step-up plan, is getting people on some type of exercise regimen that is definitely increasing over time. Because the more you exercise, the better you sleep at night. It gives you more energy during the day. It's a really nice feedback loop. Then, of course, healthy sleeping can be aided by different products. My favorite to start with is melatonin over the counter. It's good. They used to make melatonin from pig pineal glands. So I stopped using the over the counter, but now it's all synthetic. It's not, you don't have to worry about getting porcine retroviruses from the melatonin tablets. So melatonin is good at night. You have to take it 2 hours before going to bed for it to have its maximum benefit. A lot of people say, I'm going to take a pill, I'm going to go to sleep. Then 2 hours later, they said nothing's happened. Well, about 2 hours is when it's going to kick in. So I have to understand melatonin, and you can do a step up, because if you take too much, you could be groggy the next day. There's also a prescription melatonin in the US called Ramelteon, which most people don't know about. It's not often covered by insurance companies. I don't know what the pricing is on it, but that's also more potent. I think it goes up to 6 milligrams, but it's, I think it's more consistent, more potent than the over-the-counter. Then after that, I use other medications to help people sleep that are non-addictive, and I go to Doxepin next. And then if I really get into trouble, really can't get people, then be medications like Ambien, Zolpidem. So that's also a step up. So it's really working with the patient, but trying to fix that sleep through exercise, through low-level pharmacology. Some people like valerian tea. That's something that was very prominent in Scotland 300 years ago. You could get that from your local herbalist,
Okay.
and that worked for some people. So there are a few herbal teas that promote sleep as well.
Okay, perfect. That's helpful. So one of the things I would say, and obviously coming from a patient support group, I do have a vested interest. So I do have some bias in here, but we have absolutely found the benefit in terms of support networks, talking to other patients, listening to other patients, sharing with others, coming together, being seen, being understood, and doing that mutual support aspect to that gentle step up in exercise. And we talk about meaningful activity. I'm not sure if you're aware, but it's illegal in Scotland to do exercise unless you're wearing lycra. And so we try not to wear too much. No. So we try and step away from the word exercise, but talk about meaningful activity. And that sometimes it's easier to then start that step up and build up and build up, and then you can go into something more full. So again, if that is you and that's where you are in your journey, A, we would love to help, but B, let's put you in touch with other patients who've been there, who understand, and who see you on that part of the journey. Unlike most political Q&As, we're going to do follow-ups. So somebody's come back and asked, what about Asha wada? Now, I'm going to say that as if I know what it is, even though I don't. So is that anything you can talk about?
It's a herbal preparation that I believe is based on Ayurvedic medicine, which is the type of herbal medicine that you get in the Indian subcontinent. And it does have some beneficial properties, but there's also been a few cases where it's caused liver toxicity that have been published. So I usually tell people to stay away from that specific item because of the liver toxicity that's been published already. And one thing, Robert, I forgot to mention, you brought up the support network. That's very important. But really going into a patient's history about depression. Depression results in abnormal sleep, excessive sleep, terrible sleep. So really getting to that could be connected directly to the PBC, but it may also be underlying from work, from family situations, from other things, or it could be a central depression that doesn't have an external reason. But treating the depression is good. And that back to daytime. Sertraline, some of the other antidepressants give people a lot of energy. Effexor also can work for people. So getting a good depression history is key.
Okay, perfect. Thank you. All right, wonderful. Thank you very much. Okay, the questions are coming in on Facebook. So we've got people saying hi from Louisiana. We've got people saying hi from Wales. So general question now. So I'm going to just open it up. So somebody is diagnosed just after Christmas. They're still waiting their first appointment. So they're on urso, but they're waiting for their first consultation. So what can we say to anybody that's relatively newly diagnosed, new to the community, possibly full of fear, full of the unknown? What are the top 3 things that we would say to a brand new patient in terms of PBC, the journey, life expectancy, those kind of things?
So when I first meet a patient with PBC for their first appointment, I'm starting out, and this is similar with all my patients with different types of liver disease or conditions, is asking them, what do they know? What do they understand? Because people come in with information, and that's a great place to start. I didn't do this 2 or 3 or 4 years ago, learned it recently. So if you know where the patient is, then it's helpful to join them on their journey. They may be on a country road, they may be on the freeway, they may be flying at 30,000 feet. Somewhere in that metaphor, you need to join the patient to catch up with where they are. And that's really my first question. And what do they understand about PBC? And what do they understand about their current health? People are often still, even in spite of all the work we did together, Robert, stuck with that old idea that they have cirrhosis as soon as they're diagnosed.
Yeah.
So I really try to get quickly to staging through our non-invasive tests. This doesn't require a biopsy. And most of the times I can tell them, you don't have cirrhosis, you don't have cancer. Those are key words that every patient's waiting for. Most of them don't ask. And then they want to know a timeline, usually, about a disease they know that's progressive. And we talk about what happens without treatment and then what we can do with current treatments. And of course, it's very exciting now because we have 2 more medicines for PBC that we think will be approved this summer. And that also gives patient more hope. I do describe to most PBC patients that I've maybe sent 1 patient to transplant in the last 5 years because we're active working together with the patients for interventions to slow or stop their disease. So I think those are 3 key points. Did I leave anything out?
No, good answer. You're absolutely right. Deal with the fear, tackle the big words, and then provide that reassurance that, we are now looking at a long journey. And, it's taken 40 years to prove that urso works over that period. It's been going 30 years now, I think. And when I first got involved with the community, you were talking to patients who were diagnosed 5 years, maybe 10 years. Now I'm meeting patients that have been diagnosed 25 years. The longest diagnosed patient I ever met was 43 years diagnosed. And I know that the oldest member that we were aware of was 103 when she passed in the foundation. So, and those tiny little stats, I think, are really helpful in terms of painting a picture. So, no, great answer, Bob. I really, really appreciate that. I'm going to ask you about supplements. So, in terms of, so we spoke earlier, or it came up in terms of vitamin D, vitamin B12, all of those kind of things. So, what can we take safely? What should we avoid? And how do we look at supplements with somebody with PBC?
So I'm going to go down the road on supplements of nutritional supplements that are in the vitamin and mineral class, because there's lots of other supplements that we don't fully understand.
Yeah.
And in my liver patients, for my liver patients, I'm trying to assess vitamin A level, D3, zinc, and magnesium. These are what I call easily accessible, easily tested macro or micronutrients. There was a publication I just sent out to my network about a week ago. Robert, I hope you received that. It talks about vitamins and nutrients in liver disease, and especially in people with cirrhosis. It was a great paper, I thought. It brought forward everything, these four, which I know the big four. Selenium is another one that they mentioned in a pretty prominent position. I don't measure selenium levels. I don't supplement with selenium other than through multivitamins.
Okay.
So I do recommend a multivitamin every day. I recommend 1,000 milligrams of calcium a day. I think there's a question in the queue about calcium, how it comes in, and whether it has a sugar substitute, aspartame, in it. And I definitely tell people stay away from all sugar substitutes. Every 10 years, another substitute becomes very prominent, and then 3 years later, it's connected to some disease. These are not natural sugars. And of course, keeping regular sucrose, fructose, other things, those types of sugars down to a modest level.
Yeah.
But how do we not hurt people? It's don't take massive doses. And if you're on vitamin A and vitamin D, especially, you should be monitored. Zinc and magnesium can be monitored, and you hit your therapeutic level, and either you stop or reduce the dose to stay in that blood range. And vitamin D, I'm very adamant about getting the D3 level between 40 and 50. Vitamin A, it's very difficult to get people into the normal range. I think I've seen one person who got super normal, had to stop vitamin A on a patient last week. That's the first time in the last 5 years that happened. Zinc is important, but if you take too much zinc, you lose your taste and it causes nausea. So it's better to start with, say, 50 milligrams of zinc acetate, lower dose, to replete slowly. There's a paper I just read about giving PSC patients B6 as a therapy.
Okay.
It was a really good paper. I'm going to read the whole paper. I just read the abstract. So I want to put B6 out there for a discussion in the future, Robert, whether that we should be exploring that in PBC, since the diseases do have some parallels. So that's my starting point with vitamins and minerals. Any other vitamin or mineral that's a hot topic right now, Robert?
So nothing on the questions and answers at the minute, but you often hear, particularly as people are progressing into more liver damage, the worry about the fat soluble, so your A, D, E, and K. Coming back to the vitamin D tablet, though, are there tablets available that don't have aspartame in them?
I've never seen aspartame in any of my calcium supplements or combo.
Okay.
So I think it's very easy to get regular. But I saw a show on YouTube on nutrients recently, and this person said it's difficult to absorb calcium unless you're taking it with other micronutrients, including sodium chloride, magnesium, zinc. There's some others. So a combination calcium tablet with other salts is probably the way to go. I think this is a very credible biochemist, nutritionist. This wasn't hype. This person wasn't selling anything. So now I make sure I take my calcium tablets, which I have right here next to my computer, that I take every day, and I wash that down with a special electrolyte solution. So that's my way to stay bone healthy.
Okay, nice. Perfect. Thank you. All right. This is a hot topic. This is a hot topic. So somebody was diagnosed 2020. So I'm giving you the background, and then we'll have the conversation around it. So originally, their ALK-Phos, their ALP, their alkaline phosphatase, their numbers were coming down, but then they started to rise again. So we can have a conversation around urso dosage and making sure that everything is as it should be there. But what do we think about patients who were responding to urso and then suddenly their ALK-Phos starts to rise? What do we know? What do we do? How do we help?
Great question. I think the first place that we go with this general advice is make sure we have a full abdominal ultrasound. We've looked at the gallbladder. We've looked at the bile ducts. All that is super important. You've heard me on this conversation before really emphasize that every patient has to have a GGT at the same time as the rest of their liver panel. For a very bizarre story, Medicare in the US dropped the GGT from the liver panel. They said they wouldn't pay for it, so it went away. And I thought that was really foolish because the GGT is a marker of other things that may be happening or not. Yep. So let's say you have a high ALK-Phos, it's coming down on urso, ALK-Phos is going up, but the GGT is normal, the GGT is still falling. That definitely would stimulate an order for a parathyroid hormone workup. Hyperparathyroidism results in a lot of bone turnover and high ALK-Phos, but the GGT is normal in those patients. And every year I diagnose 1 to 3 people with hyperparathyroidism. And people look at me like I'm a genius. I said, no, I'm not a genius. I just did my homework and I was a medical student. I remember it. This is in all the textbooks.
Okay.
But we don't realize this because they don't order a GGT. So super important. Then, of course, we have the issues of fatty liver, whether it's from metabolic syndrome or alcohol or both.
Yep.
So people need to be alcohol free. And every PBC patient who is overweight or obese needs to have an assessment with a device like a FibroScan, or Sonic Insights has a machine called VeloCure. There's a new one from a company called MindRay called the Hepatitis scan. And each of these scans tells you liver stiffness, and it tells you how much fat's in the liver. So then we need to address fatty liver. Has all sorts of different names to it now, different initials. Yep. So I think that has to be on the table with every patient.
No, that's perfect. That's helpful. Okay. Can we talk about the urso dosage? So what is urso and what is the optimal dose and why?
So urso, the name urso comes from bear, and this is the dominant bile acid in bear bile. And back in history, we derived urso from bears. There would be sad bears with tubes in their gallbladder, and they were getting drained every day, and it was sold on the market for a lot of reasons. It does a lot of other health benefits. Now we make it in factories. It's a bile acid that is anti-inflammatory. It helps treat or prevent gallstones. It improves bile flow. It's one of our favorite bile acids because it's so friendly as opposed to a number of other bile acids that are pro-inflammatory, pro-fibrotic. So it rebalances the bile acids in a person's body to be in a more quiet state, anti-inflammatory state. And we know the best dosing is in the 12 to 15 milligram per kilogram. So everybody has to go from US pounds back to kilos. Other countries are on kilo scale, so it's a little bit easier. And I dose everything at once. I believe, from what I learned from Alan Hoffman, that everybody gets the same blood levels, um, with whether they get once a day or 3 times a day, and it's easier to remember once a day. But if they do have side effects, such as nausea or diarrhea or itching, then you can spread the dosing out, or dose decrease and dose escalate. So one sad story, Robert, from a recent survey I was involved with, I don't know if it's been published or not yet, the full paper, is that every patient with PBC is not on urso, not because they had side effects, but because their primary provider didn't start urso. Oh, you're not bad enough. Your numbers aren't high enough.
Yep.
I don't know what that number is. So it's not just the right dosing, but every person should be on urso provided that they can tolerate it. And
Hmm.
I think we know from the obeticholic acid studies, which are huge long term, is somewhere between 5 and 10% of people can't tolerate urso and have to come off. Is that 10% number what you think is correct?
So I think probably close to about 5. I think from our experience, it's certainly there or thereabouts. And one of the other things that we talked about, so people who start urso sometimes will become slightly looser in their bowel movements. And I think it's really important to talk about this, because when you look at urso and what it does within the body, it's actually flushing bile out your system, and it only has one mechanism. And so if it happens that somebody is slightly looser in their bowel movements, that actually it might be the urso is doing what we need it to do and what we're asking it to do, as opposed to it not being tolerated, if that makes sense. Any thoughts on that?
Yeah, it's talk about listening to your body, rebalancing, finding out if you believe you're having a side effect from the urso, or is it from lactose intolerance, or is there something else that might be causing loose bowel movements? So it's really about taking that history. And since we're on the subject of bile acids, maybe not now, but before we finish today, is to talk about the IBAT inhibitors, which is the new wave.
Yep.
How if you're taking that, you have to take it offset from your urso. And what the side effects of the IBAT inhibitors are is diarrhea, because you're not absorbing your bile acids that are going into your colon, where they become cathartic. They cause electrolyte movement into the bowels, and etc. So that's my picture, is teaching the patients how to listen to their body and make adjustments.
Yeah, perfect. That's helpful. Okay, so I'm going to talk about the urso dose, because we've actually, right, Bob, quick mathematics test for you. Somebody is 8 stone 7 pound. Now, I don't know if you do stone over there. I know you do pounds. So what I'm going to do is I'm going to use this.
Okay.
I'm going to look at it. So 8 stone 7 pound and 9 stone. So they're between there, which means that they are somewhere between 55 to 58 kilos.
Okay.
And so the ideal dose for them would be 750 milligrams. And that
Perfect.
is what that tells me.
Use your calculator.
Use your calculator. Absolutely. So somebody asked the question. So they're on 600. But they've not seen a hepatologist. They were diagnosed 2022. They haven't seen a hepatologist. I don't know where you are. So if you're asking this question, do let us know which country you're in, because that will help the answer. So what can they do? Their question is, do I tell my GP that I'm on the wrong dose? So again, with my patient advocacy hat on, I've certainly got thoughts and an answer, but I'd love to know your view as a clinician. If somebody comes to you and they're on the wrong dose, what would you want in terms of a helpful conversation?
I always take the positive verbiage, which is doctor, provider, pharmacist, however that person's in that prescription loop, is I heard the better dose is blank, and I did a calculation. Can we do a dose adjustment through the information I derived. Of course, I'm always asking everybody to go to your foundation website. So patients should participate. They should ask. They shouldn't be intimidated. They do need to be on the right dose to get maximum benefit from this.
Mhm.
And I think that's just the right way to take it. Be active. And if your provider isn't going to partner with you, definitely it's time to find a new provider,
Okay.
whether that's your GP. And I think every PBC patient should see a liver specialist, whether it's a gastro-hep or a person that does 100% hepatology. I think that's very important because the primary care providers can't possibly stay up, especially with the new medicines coming out. And I've treated 70 or 80 patients with obeticholic acid. Most have tolerated it or done well, I should say, on that medication. But that requires education. You have to know the package insert, you know how to stage their disease. And that's what hepatologists do. So
Yeah.
hepatology is a great way forward.
Okay, perfect. That's helpful. And coming with my patient advocacy hat on, I think if you have access to a printer, look up ESO guidelines. You've got the BSG guidelines in the UK. We at the foundation have a lay version of the guidelines, which we worked with Bob on for the US version, the AASLD. But we have a lay version of those guidelines in both the ESO and the AASLD one. So again, if you can print them off, if not, get in touch with us directly. We will send you one, and then you can take that into your doctor as well, just to again help have that conversation. Okay, we're talking about vitamins again. Now, the question mentions EDS, and I have no idea what EDS is. But it says, what about if you have EDS and your body struggles to absorb vitamins as it is? What else can you do?
We need to find out what EDS is.
We certainly do. So while we're waiting for find out what EDS is, we have another question on urso. Is it urso or is it PBC that causes bloating?
I would say there's a lot of causes of bloating. You need to definitely do a full workup and to find out what's going on. We've talked about lactose intolerance. There's issues as people become jaundiced, that they have fatty food intolerance that can cause bloating. There's a variety of different sugars that cause bloating. And there's something called a FODMAP, FODMAP diet that is a stepwise diet elimination plan.
Okay.
And that's all, I think, super important and be working. That's one of the reasons to be seeing a gastro-hep is to work people up for irritable bowel syndrome or inflammatory bowel disease. Up to 15% of PBC patients have celiac disease or gluten allergy or gluten intolerance. So I rapidly go down that gluten pathway with my patients with blood tests, maybe an endoscopy, maybe a biopsy, maybe a diet. But gluten intolerance has to be high on everybody's radar.
Okay, perfect. Thank you. Right, we have clarification. I love this. So EDS is Ehlers-Danlos syndrome.
Okay. Yeah, that also can stand for erectile dysfunction. So I really want to go which direction the patient has symptoms.
I think that's an important differentiation to make.
So Ehlers-Danlos is this collagen disorder where skin and joints are hyperflexible,
Okay.
and it is it's a genetic condition. It's not an autoimmune condition, and it does, of course, run in families because of the genetics. I don't see an interaction with Ehlers-Danlos with PBC directly, nor with any of the medicines that we use for PBC
Yep.
causing a problem for somebody who has Ehlers-Danlos. So I think that's my short answer. Is there anything more specific I should go to?
So I think it was just they had that and they were concerned about vitamin intake, but I think hopefully that gives some kind
So
of.
there may be, I have to look this up, there may be some malabsorptive issues with Ehlers-Danlos. And what I'm thinking is something called small bowel bacterial overgrowth, SBO or SBBO, that would need to be evaluated with what's called some different breath tests that you can do to figure out if that's there. And there is an antibiotic treatment for that. pro-motility agents that can help. So I would go down that pathway with your provider if I was in that situation.
All right, perfect. Thank you very much. Going back to IBAT inhibitors. So we're exploring them for itch. With my very basic, and I'm emphasizing basic knowledge, is there a potential for the IBAT inhibitors to make a difference in disease progression?
Fantastic question. I've just been learning this year so much about the two IBAT inhibitors on the market, and there's apparently at least two more coming.
Okay.
Odevixibat and maralixibat are the two that are available now for pruritus. They were developed for other conditions called PFIC and also Alagille syndrome. They're being looked at for biliary atresia.
Yep.
And of course, the itch of PBC is a major focus that's rising also to the top. And these work through binding bile acids in the intestinal tract, but really, they don't bind bile acids. Let me back up and make the correction there. They block the uptake of bile acids in the small bowel, the very end of the small bowel, the ileum. And by blocking that transport mechanism, the bile acids move into the colon and can cause diarrhea, loose bowel movements, etc. But there is great hope that these are going to improve people's quality of life and really reverse this itching. The dosing has to be offset from your urso or your OCA that you're on.
Yep.
That's super important. But there was one more part to your question, Robert. Did I miss the final part?
So because of the mechanism that it's stopping the bile acids being uptaken again, so it's getting flushed out the system, could that long term have an effect on disease progression?
Oh, so this is a very important question that I'm going to derive my answer from their use in cholestatic disease, such as Alagille's or PFIC. And I'm interpreting the data that they can stop progression and maybe even reverse disease in these patients.
Wow.
Mechanistically, it makes a lot of sense because you're taking the very bad bile acids out and you're putting good bile acids in. And if bile acids are causing the disease and you rebalance in a profound way, then you could maybe have an impact. So this is data that's not in the package insert. It's not part of the label, but I believe this is happening from improvement in liver enzymes that we see. And we know from the GLOBE study, the long-term data from obeticholic acid, real-world data, that we're impacting disease. We're stopping progression. And I think there's a hope that in some people we may reverse disease.
Wow. Powerful words, my friend. So, all right, brilliant. Thanks. Something to think about. Okay, right. We have more questions. Here we go. Diagnosed 2017 on a Mediterranean diet. Was doing well. Ammonia in the urine. And then sepsis. So inflammation is going haywire in the body. Alk phos has jumped again. So calcium oxalate is being asked about. So does this come from the liver not working properly? Should they be on a second line therapy? Can't get the inflammation under control. So I've asked that really, really badly, but hopefully I've given you enough information to. So
I'm hearing 5 different questions in there.
Okay, fair enough. Go for it.
Second. Something's happened with my battery charger. And I gotta fix that. Hang on 1 second. I'll make sure my computer doesn't die in the middle of this. Okay, I fixed that. Now, let's approach this one by one. Calcium oxalate can cause stones, kidney stones, but in my experience, that's a genetic issue and a little bit of a diet issue. Like you would be eating rhubarb, which has a lot of oxalate in it, but that's not PBC related, in my opinion.
Okay.
Number two, PBC is a pro-inflammatory state. One way you can shift your body more anti-inflammatory is to be on a vegetarian diet and avoid red meat or stop red meat intake. The less red meat and the more vegetable, fruit-like diet you have, grains, and stay as far away as possible from ultra-processed food. We've learned more and more that this great junk food that I guess America was the best inventor of is really ruining our general body health. I think that's key. This vitamin and nutrient supplements also has an antioxidant effect to it. There was a question there about sepsis, but that's probably going to require a lot more detail to think about. I don't think that's pertinent to the general PBC community,
Okay.
but of course, if someone has a fever, abdominal pain, a workup for infection is important. The one connection between infection and PBC is this connection that you know from the northern England, I think also from Scotland, around the Newcastle area, that came up with the E. coli urinary tract infection link to developing PBC, or as a risk factor for PBC because of molecular mimicry between E. coli proteins and something called pyruvate dehydrogenase that's part of the targeting of the immune system. So I'm trying to see if there's any other question in there that we need to go after. What did I miss?
So I'm reading it. So I think you've addressed everything that's in there. But if you asked that question and we missed a bit, okay, here we go. Right. So the sepsis caused the body to go into total inflammation, which then affected the liver, and that means the alk phos is continuously going up. So
I want to talk about alkaline phosphatase again. Remember we talked about hyperparathyroid workup, but there's something much more common, and that's vitamin D deficiency. Vitamin D deficiency results in a malicious state of bone turnover. It can drive the alkaline phosphatase high. Sepsis in general, if the sepsis or infection, that's what sepsis means, is infection, systemic infection. If that's resolved, the inflammation around that should resolve, and the alkaline phosphatase shouldn't be going up.
yeah.
But if you're a PBC patient and something's changed with your liver numbers, going back and getting new imaging would be important. The first step, of course, would be to get an ultrasound, but an MRCP is really the best way to define the bile ducts and the biliary anatomy.
Yeah.
There are overlap syndromes with PBC and classic autoimmune hepatitis. There's a potential overlap with PBC and what's called autoimmune cholangitis, which you really have to have a biopsy. And PBC and PSC don't directly overlap in my 30 years of experience. So if you have PBC, you're not going to get PSC or vice versa, but they can mimic each other. And theoretically, you could make an incorrect diagnosis for somebody with PSC and call them PBC or vice versa. That is really important, I think, as a reason to see a hepatologist to make sure you have the correct diagnosis.
Yeah. Okay, perfect. Thank you. So you kind of inspired me when you said, let's go back to alk phos. So let's go back to the entire liver panel. So we talked about alk phos being a good tool in terms of PBC and looking at disease progression and then looking at all of those kind of things, right? And the risk of disease progression. But we also know that alk phos is in bones, it's in the kidney, and all of those kind of things. So can you maybe talk about the challenges that clinicians face in terms of the liver panel? Very few of the tests in the liver panel are specific, and what you're actually doing is shifting the pieces around to make the jigsaw puzzle. So So for example, one of the things that in my head, so ALT and AST, and again, you can talk in much more technical terms than I can, but that's to do with cell damage and cell repair. And if you were to walk into the corner of a table and bruise yourself on the thigh, your ALT and AST would go up. So can you maybe talk about the fact that there are multiple factors that affect the liver panel and how clinicians are trying to pull out the right info to help their PBC patients?
A great starting point for this discussion is to make sure, as a patient or a provider or as an advocate, that we fix the terminology. There's still a lot of old school and some young school liver primary care GIs that say LFTs when they're talking about liver enzymes. This is terrible terminology. It scares patients. It's misinformation. And needs to be corrected. So we have a liver panel, like you said, and the two pillars are liver enzymes and liver function. In a liver panel, you get an albumin and a bilirubin. And of course, you get the three liver enzymes, AST, ALT, and alkaline phosphatase. And if you are now in our new state of the art, you'll have a GGT. So it's 4+2, 4 enzymes, 2 liver function tests. And that really is the foundation of assessing liver and also general health. The AST definitely can come from muscle, cardiac or skeletal muscle, much more than ALT. So if you have bad muscle injury, your AST is going to be 10-to-1 what you see with ALT. So if you have a super high AST in that situation, it could come from muscle exercise, could come from people on statins. I put almost all my patients on a statin, but 1% can get muscle damage from a statin, and that would cause the AST to go up. And if you think it might be from muscle, you just order another $5 test called a CK, or creatine kinase, used to be called CPK, and you can figure that out. So you have ALK phos from bone, AST, a little bit of ALT from muscle, and that puts us back to GGT, which is very liver specific. You can find GGT in other tissues throughout the body, but it's really a liver test. It's excellent, but it can be elevated for a variety of different reasons: obstruction, alcohol, fatty liver, PBC, PSC. There's other conditions that can make the GGT go up, as well as medications. There are a few medications like phenobarbital that induce especially alkaline phosphatase, but also GGT, that can make them disproportionately high. So liver panel contains liver enzymes and liver function tests. If you are a patient or an advocate or a provider or a support person in an office with a doctor who keeps throwing around the word LFTs, you can help educate them to use the current and best terminology. What do you mean, doctor? Do you mean liver enzymes or do you mean liver function? And finally, on liver function, my favorite liver function test is the direct bilirubin. This, you've been hearing me talk about this, Robert, for a few years, and I, with my team, are writing a paper on how to use direct bilirubin as a liver function test and what are the catches, what are the caveats of that. So if your total bilirubin is greater than 0.6 milligrams per deciliter or greater than 12 millimoles, your provider should be fractionating the bilirubin on their orders so you can follow the total bilirubin and the direct bilirubin.
Yeah.
So that's my diatribe on LFTs, liver enzymes, liver panels.
Perfect. Thank you. That's helpful. Got a question here. Somebody was transplanted, liver transplant in 2020. But since the transplant, they have terrible joint pain and fatigue. So can you talk a little about, so we talk about recurrent PBC, but the PBC is never cured because of the transplant, so it never goes away. But can we talk about PBC post-transplant in terms of what symptoms are sometimes alleviated just coincidentally by transplant and some that are not, and what's the best way to monitor somebody post-transplant in terms of their ALK phos levels and if they're going up or not?
Oh, great questions. This is a complex area. As you mentioned, PBC comes back by biopsy determined in at least 20 to 30% of patients, and everybody's at risk. So I think the current state of the art is you go to a transplant with PBC, right after transplant, you're back on urso forever. That's how I manage my post-transplant patients.
Yep.
If this onset of fatigue and joint or muscle symptoms is new after a transplant, I wouldn't be blaming the PBC. I would be blaming the Prograf or the cyclosporin or the mycophenolate or prednisone withdrawal, because a lot of people are coming off prednisone and they can have a withdrawal-like syndrome from that. I'm going to look for infection. I'm going to make sure if they're on a statin, the statin's not causing these symptoms. There are other medications that can cause that. So I'm going to go down that med list and really determine if there's an issue there. If their alk phos is elevated, I'm going to be thinking also about arterial injury, maybe some problem with the bile duct anastomosis, the surgical anastomosis. And there's infections that people can get after transplant because they're immune suppressed. CMV, Epstein-Barr are two classic. Herpes also can be there. So there's a huge list, and that requires a very healthy interaction between the transplant team and the patient.
Perfect. Okay, that's helpful. Thank you. Question about coenzyme Q10. So somebody's on 100 milligrams a day for about 10 months. It's helped them with the fatigue. Still a wee bit tired at the end of the day, but very much helped. Are you aware of any problems taking a stronger, bigger dose of Q10? For example, 300 meg instead of 100 meg a day.
I don't know a lot about CoQ10. I know it was a hot topic back in the HIV days because it would counteract some of the side effects of some of the HIV, the antiretroviral medications.
Yeah,
it's not toxic, so that's the good news. I don't see any downside. People are using it. Just look at the literature and try and stay in the middle of the range, not go to super high doses with this. CoQ10, I believe, is a transporter or a co-transporter for what's called mitochondrial energy generation or energy transport. So there is a physiologic purpose. This is not just placebo. It would be potentially helping something metabolically in the liver or the rest of the body. So no danger. If it's helping you, okay, stay at moderate doses. I think that's the best message.
Okay, perfect. Thank you. So I have a follow-up question, which is, if your liver isn't working properly, what other organs can be affected? But before I come to you with that question, I'm going to come in with another question first. We talked earlier about how few patients with PBC go on to develop cirrhosis. So you'll see some bridging fibrosis, you'll maybe see some inflammation, but can you talk about the inflammation, the fibrosis, and the cirrhosis, and the levels at which the liver will still operate and function well and do all those kind of things? And then we'll talk about, if your liver is damaged, how that affects other organs. Does that make sense?
Okay. Sure. So the liver's got incredible capacity reserve to function all the way up into the level of cirrhosis. So there's massive extra cells, extra capacity. You're not going to run out of liver function until people have moderate to advanced cirrhosis. And the way to measure that, simply, we talked about bilirubin before, total bilirubin elevation, direct bilirubin. Once that starts creeping up above 0.3 milligrams per deciliter, that's when I think the liver dysfunction may be affecting other things for that patient in terms of mental thinking, bone metabolism, muscle balance, muscle metabolism, amino acid balancing, making clotting factors, all the things that the liver does every day, at least 200 that we know about. So, but people really aren't going to have liver capacity problems until mid to advanced cirrhosis that would affect their quality of life or bleeding or something else. So that's my simple answer.
Perfect. No, that's really helpful. Thank you. So if you get to the point where your liver is no longer working or functioning properly, can that affect your other organs?
Absolutely. And the classic one is kidney failure.
Okay.
If the liver's failing and you're in the hospital, you're heading towards a transplant, kidney failure becomes a partner in the great majority of people, depending on how sick they are. That's called hepatorenal syndrome,
Yep.
HRSAKI. AKI is acute kidney injury. And once people have that, many of them don't live very long, might live 2 weeks to 3 months. So that's bad. But the liver is affecting diabetes and glucose management. It affects muscle balance, muscle health. Once it gets advanced cirrhosis, it's really hard to keep your muscles fully developed because glucose levels are changing a lot, going low and high, low and high. So glucose metabolism, which affects the brain, affects muscle balance, is super important. There's something called cirrhotic cardiomyopathy, where people with cirrhosis get heart, left ventricular or ventricular dysfunction. And of course, brain. I never measure ammonia levels, even though ammonia level can indicate liver dysfunction. I really examine the patient to see if they're building up too much toxins. And of course, I treat that. So the liver is what they call the seat of the soul. I think that's what the Greeks called it. So it's essential for health of every part of your body.
Perfect. Okay, wonderful. Thank you. Right, last question for today. So we know that you will be joining us for the summit using the app, and so you'll be part of the conversation and be able to throw your occasional grenade in that you do, which is really important, and for which I personally am eternally grateful. And we know the effect that we've had when we've worked together on dropping those grenades in the community. So my question to you is, so the work of the summit, we come together to look at the bigger picture issues, the unmet needs and all of those kind of things. So what do you think is the highest priority unmet need that we as a PBC community should be working together to improve over the next year or two?
I think there are two parallel issues. One is very much liver focused, and that is making sure nobody goes to transplant with PBC. Everybody's on urso baseline. We're going to have 3 second-line medications. If the alk-phos isn't normal, we need to talk about adding another medication. And of course, assessing that finally is, of course, people getting staged every year with either with blood tests and imaging. So
Yeah.
getting people on the right therapy early to stop progression, preventing transplant, that's number one. And number two is teaching providers to interact with their patients correctly. We talked about this LFT issue, but also quality of life, itching. We have medicines for itching, new medicines for itching, which are important. So I think, excuse me, going down that provider, patient, advocate, support team, called almost a multidisciplinary team, making sure that patient has the best quality of life. It's not just length of life, but it's quality of life.
Yep. No, perfect. That's a great answer. Thank you. And we will take that into the room. So thank you so much. We've got one more question that's just come in now. Somebody is fighting with their autocorrect. So I'm not entirely sure I know what the question is because the autocorrect is kicking in and changing the words. So they're asking the difference between primary biliary cirrhosis and then primary biliary primary cirrhosis. So I don't know. So can you maybe talk about the name change and just very, very briefly, because I want to be respectful of time, but talk about the difference between primary biliary cholangitis and primary biliary cirrhosis and why it's no longer called primary biliary cirrhosis.
So historically in the 1950s, when this disease recognition was developing, and of course it dates back much, much further, because I think there's been 7 different names I've heard for this disease. Most people had cirrhosis because there was no treatment or no recognition. So it was easy to call it biliary cirrhosis because it was bile ducts and cirrhosis. As urso came out, earlier diagnosis, many patients did not have cirrhosis, and people don't want to be labeled as cirrhosis if they don't have it because of social stigma and the connection to an alcohol use disorder. We used to call it alcoholic. So we wanted a name that reflected the disease, but helped decrease or remove the stigma. And you and I, Dr. Brewers, David Jones, a lot of other people, hundreds of people collaborated for the name change because it was the right thing for the patient and it was the correct terminology for the medical community.
Perfect. Okay, wonderful. Dr. Bob Gish, thank you so much for your time and all those answers. Absolutely incredible. Pleasure to see you. Sorry we won't be seeing you at the summit, but I look forward to your comments and questions and challenges, and looking to see you throw the odd grenade as well. So if you have joined us on Facebook, thank you very much. Have a great day. If you're here in Click Meeting, then thank you very much for joining us. Bob, take care, my friend. Lovely to see you.
You're great. Thanks for your leadership. Say hi to your mom.
I'll pass that on. Thank you. Take care. All the best.